Hey guys, welcome to today's show. This is Dr. Steve, and we're going to talk all about growth in hospitals and health systems. It's a powerful show on the next era of capturing consumers and patients, right here on Red Hot Healthcare. Let's go!
3 alarm and 21 and north. All engines respond.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com.
Hello everybody, it's Dr. Steve, and today is Monday, August 7th, and we're going to talk all about growth, and the growth that's necessary, I believe, to see the next stage of healthcare be more successful than ever. Let me start off by saying just for S&Gs, and by that I mean snickers and giggles, I want you to do me a favor. Go into your LinkedIn, and under your LinkedIn search, I want you to put a comma in the field. Go ahead and hit search. There should be close to 143 million people that come up. Now I want you to go in and select keywords. Under that, put Chief Growth Officer. So once you hit search, you'll find a little more than 1,300 results. Then I want you to go to the right under Industries in the field and select Hospitals and Health. Now you're going down to 91. I want you to go through each one. It'll be about 9 pages worth. Just weed through all the companies that aren't actual hospitals or health systems, or I'll just go ahead. I'll save you the time and trouble. You're at 6. There are just 6 chief growth officers within all senior leadership in nearly 6,000 U.S. hospitals and health systems. If you're not satisfied with that, no problem. Just Google Chief Growth Officer Hospital or Chief Growth Officer Health System, and then you can start rolling through page after page and not finding too much. Well, I'm going to get into this growth title, this Chief Growth Officer title, mostly in the consumer market space, and that's going to have a role to play in this discussion here when we talk about consumer markets. Back in 2004, Chief Growth Officer really started to get its wings. It started fizzling later during the recession. Now it's coming back again as of late 2015. And at this point, we have about 40% of the chief growth officers sitting in companies smaller than 50 employees. And then surprisingly, chief growth officers are now into the leadership hubs of the largest consumer darlings. So we're talking about companies like Hershey, Kellogg's, Coke. In fact, Coke recently made a major change in the way that it looks at its growth. It replaced its chief marketing officer, that role that it's had since 1993, actually replaced it with a chief growth officer, switched out one person for another. This is really coming on the heels of the last 3 years where the company's really seen decreasing revenue and earnings. So the pullback, a really big surprise for Coke, especially since 2011. Coke really made what I thought was a smart choice in shifting from a traditional advertising model. It moved into a new era of content marketing. You know, this is a company that had a lot of historical success. I mean, it's an American icon, and for over 100 years, it essentially decided to trade in all that historical success, all the billboard ads, all the mass-distributed commercials. It traded those all in. It went with social media. It went with online storytelling videos. It went with real-time experience of the consumers. And Coke even went so far as to redeploy itself into a split soda can. It actually had a different soda can for a while that you could go and you could split it in half. You could share Coke with a friend. What they really couldn't share, and what wound up biting them, was the fact that the market changed. Consumers started to recognize that healthier lifestyles were really in. I mean, those choices were more than just talk. People were actually voting with their wallets. When you start looking at Coke, what do you think of on the negatives, right? You know, gaining weight, You think of, if you take Diet Coke, artificial sweeteners. You think about type 2 diabetes, acquiring that later in life. Basically, consumer behavior in purchasing Coke is really moving beyond that long-lasting, long-time desire that everybody had for this cold, bubbly feeling on their lips and the sweet taste on the back of their tongue. CocaCola and its many, many carbonated drink partners, sugary brand partners, moving out of favor right now for healthier beverage options. The company really recognized that it carried a confirmation bias, and this was kind of surprising. I mean, even for a company the size of Coke, with their intelligence, their talent, it just really goes to show that confirmation bias can hit any company at any time and for any length. But the consumer market really is the clarifying force. So we get to Coke inserting a chief growth officer. And it's really not just about their fixing a miscue that they might have had in their marketing or their marketing leadership. Basically, a chief growth officer is not the same as a chief marketing officer. It's a nuance that a lot of people really don't get. And when you do get it, you see where there's new value. The chief marketing officer historically drove creativity, brand positioning, awareness, and they also drove growth. But a lot of the leaders in the C-suite drive growth. That's not all they do, and that's the difference. The chief growth officer is essentially a reportable advisor to the CEO, and its focus, or his or her focus, is solely on growth. They intersect a blend of results and tactics and operational efforts and all the numbers that come from those, and there's 4 key areas that they look at. Marketing, sales, product, or in healthcare's case, it would be service, and finance. So marketing, sales, service, and finance. And the chief growth officer looks at so many different methods to keep their organization growing. That's all they do. So it could be rapid experimentation guys. They could be cutting across different marketing channels. They could be looking at new product development. They could be looking at disruptive innovation, sustaining innovation, looking at new strategic partnerships. Certainly, they're heavy on the consumer and customer insights. They're always focused on that. But it's more of a blend, and it's important to recognize that they're not really a carve-out just into marketing and advertising. The need for a chief growth officer, it's not just driving sustained growth as part of company strategy, but a chief growth officer really understands that even if you're a behemoth, even if you're a big branded behemoth company like a Coke or an HCA Healthcare, the days of easy growth are over. The CGOs really optimize the resources they have. They expect cutting-edge marketing. They're always building efficiency and capacity, recognizing that essentially they have to make good investments and make sure the ROI is good on those investments, but they're always looking for growth in every and any area. There's nothing that is essentially off limits for the CGO as long as it stays within the core strategy of the company. And so essentially this brings us to what we talk about, consumers versus patients. This is really where the rubber meets the road in healthcare. For hospitals, for health systems, and really for all other types of healthcare service providers, it's really important they recognize the role of the healthcare consumer. And by health consumer, I'm talking about people that are not patients yet. People that maybe are inactive patients. They once were patients, now they haven't seen the doctor in 2, 3, 5 years or more. Maybe they're existing patients at another health system or provider, and they're really unhappy with that experience. And because of that, they're not really managing the care the way they're supposed to be doing that. And so one of the things that I want to bring to this conversation is the fact that in the future, health consumers, no matter how they're segmented and they're targeted and they're positioned for, all health consumers are meant to be competed for. That is one of the areas that healthcare has not done a great job in, is competing for customers, and we're going to get into that. One of the great glories of capitalism, if you look at this country, is competition. In a free market, you have firms competing, they provide goods and services, and they employ for their competition a lot of facets, including price and quality, right? they're going to go ahead and they're going to be the cheapest, or they may have the best quality, or normally it's a combination of both. But price and quality are big metrics when it comes to consumers evaluating whether or not they want to buy a product or a service. And this happens in nearly all consumer markets, certainly in the U.S. Consumers and customers are going to benefit because what winds up happening with competition is the quality goes up, and in time, you've got lower competing pricing. Because what will happen is as costs go down for these companies to deliver products, to deliver services, then they will go ahead competitively and pass on those lower costs in the form of lower prices. And so this helps them to actually be more competitive and gain that market share from consumers, which eventually, may become customers. A lot of medium to large scale providers, your hospitals, your health systems, they've had a huge run over the last quarter century. Some people would even say the last 40 years. The biggest reason this has happened is because chiefly of a fee-for-service system, a system that essentially had predictability in payment. It encouraged overbilling, overtreatment. It also did really very little to improve quality care. Just not a lot of stimulation from a fee-for-service system to make the outcomes get better. Because you did the service and you got paid for it. I mean, unless you did something that was malpractice, pretty much if you got D-rated service or A-rated service, they both got paid. And so we know this is changing now, but at least for the last 40 plus years, we had a payment environment which essentially allowed healthcare-related costs to skyrocket. And when I talk about the costs shooting up, this is really important to understand, guys. We're talking about since 1950, almost 70 years ago, in healthcare, the average costs have gone up 274 times. You compare that to the average industry in America, we're talking only 8 times what it was in 1950. That's tremendous, okay? So in any other consumer industry, what would have happened is as those costs went through the roof, consumers would have backed away and they would have said, we don't want this, we're not standing for this. But there were a lot of factors that kept consumers ideally from leveraging their power to start bringing prices down and demanding for more. Some people might call it white coat syndrome, that, the doctor back in the 50s, 60s, 70s, and 80s, the doctor was God and whatever they said went. I think everybody was making money. The economy was growing at that time over the last 20, 30 years. People just didn't see that creep coming up. And one of the biggest things that happened was wages really stagnated for many Americans. There were people that shot up and made lots of money. And so a lot of times what people think is because their work covers their insurance, their health care, they assume it's covered. Well, in actuality, what really winds up happening is it falls on them. They're just making less salary. People don't think like that, but people need to think like that because at the end of the day, it all gets figured in to salary. Moving forward, the death knell that I feel like for what we have today, which is mass unaffordability for healthcare products, for healthcare services, for healthcare coverage, this mass unaffordability really seems to come from a lack of pricing competition. So we had price regulation from the payers. You have third-party payers, whether that be Medicare, Medicaid, commercial carriers. But what that wound up doing chiefly was it killed pricing competition. So you could not have free market forces. You couldn't have providers competing on price. And with that removed, there was really no need to do anything other than just keep rising on costs and prices, especially when most of these health systems and even most of the health payers are publicly owned. Their motive is profit. I mean, that's the motive of any for-profit company, is to make profit and to satisfy the shareholders. So they're doing exactly what they're supposed to do. The problem is we just don't have a system, or we've never had a system in place to effectively cause those entities to compete against one another and start driving down price. And the funny thing is, even today, when you start hearing all in the news about healthcare costs have to go down, hospital executives, drug company manufacturing executives, payers will start talking about we got to lower costs in healthcare. We got to bring down the costs. Isn't it funny that we never hear the second part of that, which you'd hear in any consumer market, which is we got to bring down costs so that we can also bring down pricing. You don't hear that in healthcare, and that's very important. Really, for decades, the cost of healthcare services as they were going up really seemed almost unnoticed, because what wound up happening was there was just increasing demand for services. There was increasing demand for drugs. There was increasing demand for healthcare surgeries. And ideally, what wound up happening was the healthcare system grew and grew and grew, and people just assumed that they were getting better quality care. What they didn't realize was that it was slowly eroding underneath them, and now that's all caught up. This is Dr. Steve Ambrose. As a healthcare influencer, I'm in contact with some of the brightest minds and most powerful leaders in the industry, but my best effort comes from outside the booth. Knowing how to engage patients is an art, science, and philosophy that I know very well. I'm a hired gun that brings expertise to healthcare organizations of all types. You've heard my words. Now read my thoughts on my free white paper called The 7 Mistakes Made in Patient Engagement. Just go to redhothealthcare.com/learn. That's redhothealthcare.com/learn. While you're on the site, dive into my consulting and speaking services and schedule an initial call. You won't regret the uniqueness, benefits, and results I can deliver for you. And now, back to the show. In the last 5 years in particular, what we're seeing is a greater cost shift from the payer to the plan member. And I don't think this comes as a major surprise when people see that their deductibles are through the roof now, their out-of-pocket expenses are way up, even the drug share costs are soaring. This is resulting in something that has been very surprising for a lot of hospitals and health systems and drug companies. Patients aren't doing things such as filling their prescriptions. They're not completing their therapy. The surgeries that they would normally just elect to have, they're getting pushed off now. Somebody gets a hip surgery at 60 years old that's covered by a commercial plan. They're going to wait now until they're 65 until Medicare is there. And so this is making a big difference. Not only that, but hospitals and health systems have an incredibly difficult time with patient collections, with self-pay collections. It's always been difficult, and now that it's gone more to the side of the patient with their responsibility, it's even more difficult. 2010, we see the emergence of Obamacare. Then we recognize that with the installation of Obamacare in the next few years, we start seeing that health coverage really isn't the same as healthcare, right? That the industry, the politics, they shifted their sight at that point onto what we call value-based care, which is where we're at right now. The truth is, whether value-based care rolls out tomorrow or in the next couple years, health payers and drug companies and health providers are not going to want to operate as true competitors. Even now, there's many health systems and hospitals where I know some of their executives, and they've told me 80% of their patient base is still fee-for-service. And again, I think it's important to take a step back and recognize there's a difference between healthcare business and healthcare. If I'm in the business of healthcare, and if I have a for-profit company or a hospital or health system, let's say, my job, while certainly to give high-quality, excellent care and good results, is primarily to make profit. I have to make a profit, and I got to make a profit every financial quarter, or we start losing shareholders. That's a fact. And I think a lot of people don't recognize that focusing on the patient versus profitability, they're not always going to be on the same side of the line. And so ultimately, it's important to recognize, again, the business of healthcare is not healthcare proper. What's happening now is because the costs are going up to a point where people are having to shoulder more of the load, the market is starting to adapt. It's adapting not into just value-based care. We're seeing new innovative services. We're seeing new products. We're seeing new arrangements for patient care. So what are we talking about? We're talking about going around the payers, hospitals and health systems contracting directly with self-insured employers geographically. We're talking about retail clinics, right? Clinics that have shot up. From 2006, they had about 350 nationwide. Now there's over 2,000. Talk about on-site primary care. I got a friend of mine, his company has over 200 on-site primary care locations right within the company. We're talking about direct primary care, where doctors have actually jettisoned themselves out of health systems and hospitals, and these primary care doctors are taking less money but enjoying life more, and they're giving more time and quality to their patients. We're talking about super TPAs, and we're talking about the self-insured companies all across America who are taking a much deeper look at their healthcare costs. They're forcing those ASOs that are managing the claims, they're forcing them to turn over the data, which these insurance companies don't typically do. And when they're looking at the data, these self-insured companies are saying, you know what? We can be smarter, we can do better. A lot of this innovation is already happening, but within the hospital and health system leadership, there's growth that needs to happen. They can play a huge role in the way that this entire healthcare system shapes up. And in time, I suspect what's going to wind up happening is that they play a strong enough role that the role of the payer will increasingly get lower and lower as we move forward, especially as more hospitals and health systems become integrated. That is, they offer their own insurance policy. So in full candor, I've enjoyed a past career being a healthcare provider. I was a health tech entrepreneur. Then I finally led consumer strategy and outbound digital marketing. It's given me a much wider view of the consumer mindset, the ability to tap into consumer stress and behavior, to find the right triggers to get them to take the desired outcome. More of that needs to get into healthcare. It is now, but it needs to come in, I believe, less on a vendor level and more on an internal leadership level for hospitals and health systems. As I choose an opportunity for the next phase of where I want to land, I'm pleased to see that hospitals and health systems over the last 5 years, they've added more leadership roles in technology and nursing and physician and patient experience. All those roles, I think, are very supportive, very, very helpful. But now it's time to take the next big step. 15, 20 years ago, what was the big step for providers? They formed health systems. Why? Because they recognized that as insurance was tightening up, if they could geographically control entire cities, entire counties, in some cases half states, then they could get certainly much better coverage, work on volume, and better leverage in terms of negotiating with insurers. I expect that same model of growth is what's going to be needed in the next 5 to 10 years to really solidify their place and their leverage in being stronger drivers in this industry. And let's face it, guys, there's a lot going on right now where people are just throwing things up against the wall. We're seeing it in politics. We're seeing it with bloggers. We're seeing it with so-called healthcare experts and economists. People are simply throwing things up against the wall and seeing if it sticks. We're seeing lots of new investment in digital health. We're seeing lots of investment into new technology such as blockchain. But when it comes right down to it, it makes me think of one of my favorite quotes, which comes from Mike Tyson. Quote, "Everyone has a plan until they get punched in the mouth." And I love that quote because the punch to providers of all sizes is that consumers and patients today have a greater financial role than ever. What hasn't been realized by consumers is that they can be better shoppers. But also from the hospital and healthcare side, they haven't realized that they can offer more and they can grow more and they can capture more and they can compete for more. And being able to grow now, especially in the face of uncertainty, through investment, through smart growth strategy, and by having the right type of leadership with a chief growth officer is going to be absolutely key. Larger shifts to patient financial responsibility, it doesn't mean that everyone's poor and they can't afford services, all right? There's lots of people with lots of money. So if you're, let's say, a specialty center or a specialty hospital and you want to compete more on quality, less on price, then you should be able to go out and target those people. There's a lot of people to target out there, and a lot of people want to be catered to that have money and that don't mind spending money to get the very best. However, there's a lot of Americans that can't afford care, right? Those companies that properly grow, and they can segment, they can target, they can position, they can capture patient base. They can work off of larger volumes. They can work off of using telehealth and telemedicine. Even if they're not able to, let's say, do surgery on somebody who's remote right where they're at, they can still capitalize on the entry services, the supportive services, all the sort of consulting and engagement that they can do. And look, in time, as they start getting larger and larger pools of remote patients in terms of expanding their footprint, what does that mean? It means more M&A opportunity. It means more partnering possibilities. There's all sorts of ways to think about this. But what needs to start going away is this model of we're only serving people in our community. Because in time, crossing over state lines for telehealth and for insurance payment, a tremendous opportunity for hospitals and health systems to grow. They've got to take advantage of this. It's not going to be inconceivable that in 10, 12 years from now, some of the medium-sized hospitals and health systems today may wind up being dominant players because they made the investment, they grew, and they had better strategy. They captured more patient base. They perhaps worked with them on price. In the long run, they built up loyalty. This concept of hospitals and health systems, kind of like the old Coke guys, branding based upon loyalty and a name, that's going away. There's got to be smarter drivers into capturing patient base. We talk about the Chief Growth Officer, well suited for, well needed by health providers who will seek to compete, capture, grow. They want to sustain profitability. Certainly that growth has to be efficient. But the nice part about this is when you start capturing larger patient bases, whether it's locally or remotely, it works whether you're in a fee-for-service or value-based care environment. Because what you're doing is you're still focusing on volume. You're making sure the services are needed, that the outcomes are good, certainly the efficiency is there, that growth is profitable. So keep doing all your triple aim, focus on de-risking, making sure costs come down, making sure quality outcomes and satisfaction goes through the roof. Use your technology. Make sure you tighten things up. Cybersecurity, all those things, very, very important. But at the same time, you need to have an expansion mindset at investing in expansion that's scalable and investing in expansion that's profitable. That's where tomorrow's hospitals and health systems are going to make a tremendous push. Patients are going to be competed upon, captured, they're going to have their loyalty gained, and certainly when we start talking about population health, to actually have healthier communities, whether they're local or remote, the bottom line is you need to have loyalty as a core staple. If you have consumer and patient loyalty, then you're going to be able to drive much better adherence and results. I want to thank you for tuning in today. Have a great rest of your week, and we will be back with another podcast soon enough.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.